Good evening. I'm Kelly Gear-Ripken, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, thank you for joining me this evening for our monthly webcast series, Healthy Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. Psilocybin is a chemical in certain types of mushrooms that grow on nearly every continent. The Johns Hopkins Center for Psychedelic and Consciousness Research is leading the way in exploring innovative treatments using psilocybin. Tonight, we are joined by Johns Hopkins psychiatrist Mary Yaden, who will be providing an update on the use of psilocybin in research and clinical settings. So please use the Q&A on your screen to ask your questions to Dr. Yaden, who will respond during the last 20 minutes of our program. Tonight, our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance. And you can visit their website, hopkinsathome.jhu.edu, for additional lectures and courses throughout the year. A Woman's Journey acknowledges the support of the Wiglicki Family Foundation, sponsor of Healthy Conversations That Matter. And now it is my pleasure to welcome Dr. Yaden.
Hi there.
Hello. Good evening.
Hello. I am so delighted to be here tonight. And I was just remembering that it was this time a year ago that I had the pleasure of presenting at a Woman's Journey event.
Yes.
And I was uh, actually on my maternity leave.
Yes,
So
I can't believe you came in and graciously spoke about this subject matter, psilocybin, that we're going to talk about tonight. So I thought it was amazing that you did that in your maternity leave, and so we're very honored that you're here this evening. So thank you
thank you.
again.
I appreciate it. I feel like you guys have now been on my woman's journey just with this,
Oh,
and that it's,
yeah.
the many
Well,
stages of.
that's what it's all about. Women supporting women. That's a good thing.
Absolutely. Well, I appreciate you guys supporting me, and I'm really excited to talk tonight. And so I'll just start by
We are
saying,
too.
nothing to disclose. And I'll just give you kind of an overview of where we're going. And so, first I'll just start with kind of a brief introduction. We'll talk a little bit about what is psilocybin. We'll talk about some of the promises of psilocybin research, what's really exciting about it. I'll talk about why the psychedelic treatment model itself is somewhat unique. But I'll also talk about the pitfalls and some concerns, and I think important points of caution about psilocybin research, as well as kind of pointing into the future. How does that sound?
Sounds great. Perfect.
Great, let's do it.
Let's do it.
So why am I here? I just wanted to start out just kind of speaking from my heart, and that I love being a psychiatrist and I love taking care of women, and that prior to my work exclusively in our psilocybin lab, I had was really seeing patients in a reproductive psychiatry clinic and had the great honor of taking care of so many individuals, women in particular, who are struggling and are eager to find new innovative treatments that can support them. Women work so hard that I feel like, the more support they have, the better it is. And so I am excited to be a provider who hopefully helps support transformative change across the lifespan. And so, I do this work in research because I am hopeful that there are increasingly new and innovative, exciting treatments on the horizon. And hopefully I'm speaking about one tonight. So, but a caveat, as much enthusiasm as I have speaking about this topic, I want to also really be clear that I am speaking only about the research context. Right now, psilocybin, this medicine that we're going to be discussing at length, is considered a Schedule 1 drug, which means that there's really no established benefit outside of the research context. It has not yet been shown to be beneficial. And for many cities and states, it remains illegal. There's one kind of exception, and you may have read about this or seen it in the news, that Oregon and Colorado have something called supervised adult use of these medicines. And so I can't really comment about those programs in particular, but I can say for Maryland and for most of the United States, these are only really used within the research context. So before we dive into psilocybin, what exactly are psychedelic medicines? And so this is a definition from a paper that I was a part of that really kind of got clear about what are we talking about, because we're increasingly seeing psychedelic medicines in the news. And I'm going to get a little bit specific here with this definition, so bear with me. The first thing, the first kind of, I should say, definition of a psychedelic, such as psilocybin, is what we think of as a classic psychedelic. And so this means that it has receptor activity at a very specific serotonin receptor in the brain. And again, I'm including this here for specificity, the 5-HT2A receptor. You don't have to remember that. There is no quiz after this, but this particular receptor in the brain does seem to lead to some non-ordinary states when activated by medicines like psilocybin. I'll also say that there are some cousins to psilocybin that are not considered classic psychedelics that we may bring up in conversation this evening. Specifically, I'm thinking about MDMA, or what's known as kind of the street drug ecstasy, which recently was heavily represented in the news because there was a drug application that was actually not approved by the FDA. And so there are a number of other psychedelic medicines that work slightly different than psilocybin, but also induce these non-ordinary states of consciousness that can lead to transformative change. So we'll speak more about that, but I just wanted to kind of set our frame as a definition of psychedelic medicine before speaking more about psilocybin. So you may have heard of psilocybin, even if you've never heard that term before. It is the active ingredient of what is, kind of colloquially described as magic mushrooms. I also have to say that I used a ChatGPT to help me generate some of my images for this presentation. So there are far too many Hopkins themed mushrooms that show up here. So I apologize in advance for that. But for lack of a better term, psilocybin is often described as kind of magic mushrooms. And again, it binds to that very specific serotonin receptor in the brain, leading to kind of a non-ordinary psychological state that lasts several hours. And we're saying anywhere from 6 to 8. It can be associated with feelings of expansiveness, connection, awe, as well as sometimes things like anxiety and fear. And again, this is used within clinical research in the psychedelic treatment model, which we'll describe in a little bit, just about how is psychedelic treatment a little bit different than other modalities. So a little bit about history. Psilocybin has a long history of indigenous use, specifically within Central America, and was used ceremonially in different healing practices, but was really first studied by US scientists in the 1950s. Research in the 50s and 60s was actually very robust in psilocybin as well as LSD, which was able to establish kind of the relative clinical safety in some contexts of these medicines, kind of early research and therapeutic potential in a variety of medical conditions. However, in the 1960s, in the kind of the midst of all of the political upheaval of that time, and this kind of heavily embraced counterculture took on psilocybin, and in 1970, it was outlawed by Richard Nixon in the Controlled Substance Act. So what this did not just make recreational psilocybin or LSD use illegal, it also made any kind of ongoing research in this area kind of shut down, kind of a long period of prohibition for almost 30 years. So this brings us to kind of the Hopkins part of this story. And in the early 2000s, a researcher named Roland Griffiths began exploring the use of psilocybin in healthy volunteers. Roland was a dear friend and the founder of our lab, and was someone who was deeply curious about the world. and was very eager to learn about medicines that were maybe not as uh, readily explored, and had contributed to tobacco research and uh, caffeine research over time, and really turned his eye to psilocybin in the early 2000s. So initially, he was looking at healthy volunteers and just kind of individuals like, can we do psilocybin research again in folks that are healthy? And then he began looking at things with more clinical populations. And so I'll talk about kind of two of those studies and some of the outcomes there. And 2019, he founded our center, which is now one of the leading psychedelic and psilocybin specific research centers in the world. And so we all feel really grateful for Roland's legacy. He passed away from cancer a little over a year ago. And so we all miss him very much. But his legacy really does live on in this work. So what did these early studies show? I think this is kind of interesting. This was one of the very first, if not the first, that kind of happened after the prohibition on psilocybin research, looking at healthy volunteers or healthy participants who came in and were offered a dose of psilocybin or a dose of a placebo, which in this case was like a small dose of Ritalin. And what they found is that not only was this kind of a well-tolerated medicine, that there weren't any big adverse events or big concerns that came up, but that many of the participants in this study actually considered their psilocybin experience to be one of the most meaningful experiences of their lives. So this chart here shows, many of the folks in the active treatment group here saying that their psilocybin experience ranked amongst the top 5 most meaningful. Later, Roland contributed with a number of other researchers to a study looking at specifically existential anxiety and depression in folks who had a life-threatening cancer diagnosis. So I think this is a really moving study, and that it looked at, again, it was a placebo-controlled trial where they administered high-dose psilocybin as well as very, very low dose, and kind of that was the control group. So it's almost as if they gave them no psilocybin, and really wanted to see in folks that are really facing the end of life, can psilocybin meaningfully reduce fear and depression? And they again found that even kind of 5 weeks after their single psilocybin session here, that individuals had clinically significant reductions in anxiety and depression. So I kind of teed up those two studies, but I feel like Anderson Cooper can speak to this far better than I, and so I'll let you guys play a brief clip. But yeah, go ahead.
It was certainly freeing for Carrie Pappas, though her cancer has now spread to her brain. Her crippling anxiety about death is gone.
Yeah, it's amazing. I mean, I feel like death doesn't frighten me. Living doesn't frighten me. I don't frighten me. This frightens me, but...
This interview frightens you, but death doesn't?
No.
It turns out most of the 51 cancer patients in the Johns Hopkins study experienced significant decreases in depressed mood and anxiety after trying psilocybin. 2/3 of them rated their psilocybin sessions as among the most meaningful experiences of their lives. For some, it was on par with the birth of their children.
To this day, it evolves in me.
It's still alive in you.
It's still absolutely alive in me.
Does it make you happier?
Yeah, and I don't necessarily use the word happy. Comfortable. Like comfortable. I mean, I've suffered from anxiety my whole life. I'm comfortable. That to me, okay, I can die, I'm comfortable. I mean, it's huge. It's huge.
Well, Anderson Cooper certainly has a way with words. He's got it.
He does. He does.
Thank you for sharing that.
Yeah, I love it. It's an older clip, and yet it's one that I continue to return to just because that participant is so inspiring. And so thank you. So what exactly is going on here? It's kind of a remarkable account of someone's experience. And by no means do I want to say that that is everyone's experience who has a psilocybin treatment. And yet, clearly, there is something at play here that is worth exploring, worth researching. And so I just want to introduce you all to how this treatment looks a little bit different than, say, conventional psychiatric treatment for depression, where you take an SSRI every day and it's, you may not ideally notice any outcomes other than that you feel better. Whereas in this treatment paradigm, uh, most folks know that they've taken a medicine on the day of their dosing session. And so I'm going to kind of bring you guys into the clinical trial process because, again, this is not a clinical treatment at this point. It's really only happening in the research domain. So our studies always start out with heavy screening. And so this is kind of I think, an important safety measure within our trials, but also can be a place of heartbreak because I know a lot of folks are eager to participate in this research. And so screening is a big part of our studies. And then we move into this phase of preparation. And so this is when not just one, but two facilitators, as depicted here, meet with our participants for a number of preparatory sessions. And sometimes we call this psychological support in the event that it's a kind of a healthy volunteer study. And then in other contexts, it takes the form of supportive psychotherapy or other kinds of therapies where these initial sessions are really about getting to know our participants, helping them feel safe, helping them learning their life story and their words so that if things arise on dosing day, we're there to provide support for them. And then the day of dosing is the only day in which we administer psilocybin. So it is a full day. We have folks come in early in the morning to our lab. They lay down on a couch just like this, wear these exact eye shades, and they take a synthetic form of psilocybin. Typically within our studies, we use high dose psilocybin, and they spend the day with, eye, eye shades on and headphones on, usually listening to a classical music playlist. And myself or another facilitator is in the room with them all day. We don't engage often in talking, that this is really a time for those individuals to turn inward and do their own exploration. But we are there if anything comes up and to provide general support at any time. Following this, folks usually like to have an opportunity the day afterwards to explore what came up for them. And so this starts our integration process. These are, again, those kind of psychological support sessions or integration sessions where we really allow the participants to make their own meaning about what came up for them in this psilocybin dosing day. And then, following, typically 4 to 6 sessions of integration, we then move into kind of a long-term follow-up period where we check on folks for 6 months or a year out just to see how they're continuing to make meaning out of their psilocybin experience. So a little bit different than taking a pill every morning, but a really meaningful process for both the facilitators as well as the participants. So I just want to give you guys the landscape of what are the different kinds of illnesses or disorders where we are exploring the use of psilocybin in the research context. So I talked a little bit about psychological distress in folks who have cancer diagnosis. There's been now a number of studies showing some potential benefit here. We also have an ongoing study at our own center looking at obsessive compulsive disorder and psilocybin. There's also been a number of other studies that have been published on this. Treatment-resistant major depression, as well as just general major depression, is another area that we'll speak a bit more about, because I think this is really probably where psilocybin will receive its indication in the future if it is approved by the FDA, as well as in the context of substance use disorders. And so here's a study of tobacco and alcohol. And I think this particular topic, looking at psilocybin for substance use disorders is one that often surprises people because they're used to thinking about, oh, well, psilocybin is a drug that people are abusing in the community or using recreationally. How could you possibly use it to then treat a substance use disorder? In fact, in the lab, our lab, as well as others across the country, are really showing some pretty stunning results. And so there was a pilot study done at our center now many years ago. And since then, we've replicated this study. And I can't present on those results that this particular PI has done, but I can say that it's really encouraging. But the initial study, the small pilot, showed that almost everybody who participated in a smoking cessation program using psilocybin was abstinent from nicotine products at a year. And so I just give you a comparison. Chantix is kind of the gold standard. This is varenicline. At a year, only about 20% of patients are abstinent from nicotine at that time. And so, I can certainly say that we're beating Chantix, but more research is really indicated here to show its superior efficacy. Also, there have been a number of trials looking at alcohol use disorder and psilocybin, one recently out of NYU in 2022. And our lab is now looking at comorbid major depression as well as alcohol use with psilocybin. So kind of within this framework of substance use disorders, there's ongoing research looking at cocaine use disorder, opiate use disorder, as well as cannabis use disorder. So I think a really exciting domain for psilocybin research. So again, depression is probably has the most accumulated evidence in terms of efficacy. And so in the next 3 to 5 years, it could be that one of two big pharmaceutical companies that are now funding large scale phase 3 trials in psilocybin, specifically one called Compass Pathways, as well as USONA, will likely be moving towards that new drug application within the 3 to 5 year timeframe. Several studies have shown likely benefit for folks who have depression using psilocybin within the clinical research context. And one study in particular from a few years ago out of a center in the UK showed at least comparative efficacy to SSRIs, but again, quite different, and that we were talking about kind of a single dosing session versus sustained use of SSRIs over time. So I have hyped psilocybin. I've told you about all of the promising research. I've told you about our lab. I've told you about how the treatment model is different. And now I want to qualify all of this in that there are an enormous number of pitfalls within the world of psychedelic medicine. And so I just want to kind of go one by one and start this conversation, really nuancing this enthusiasm around psilocybin. So first, I'm going to talk a little bit about safety. So importantly, in red, that we are very much still learning about the safety profile of psilocybin. We know from a few initial studies, again, kind of we're still in the infancy of psilocybin research, that there is some reassuring factors about it. However, we do not know long-term the safety outcome data in outside of the research context. So again, there are the program in Oregon, these, psychedelic tourism sites, by no means can the research that we are doing in our lab and in specific labs across the country speak to the safety and efficacy of these treatments outside of that context. So key. I will say that psilocybin is non-reinforcing. So what that means is that we don't expect in animal models or in people models that there is addiction or dependence that occurs with psilocybin. So, in those, animal models, they often say that when an animal or a mouse model uses psilocybin, they don't come back and try and get more of it. They've probably had enough. Psilocybin has overall low toxicity. So this means that, by no means are we encouraging large or very large doses, but that it's unlikely to cause significant toxicity. However, psilocybin is known in some folks to cause distressing psychological experiences. And so if you've ever colloquially heard people refer to as a bad trip, these can absolutely happen. And within the clinical research setting, there is significant emphasis put on developing a certain mindset as well as a clinical setting to put people at ease to prevent these kinds of distressing psychological experiences. So we actually refer to them as set and setting that let us really control things to keep people feeling well and safe. I will also say that most, if not all, of the studies to date, certainly in this kind of new era of psychedelic research, exclude certain diagnoses that may be made worse by the use of psilocybin and other psychedelic medicines. And so, specifically, what I'm referring to is psychotic spectrum illnesses. So, those that do have, where folks may develop psychoses, schizophrenia, bipolar 1 in particular. And so we don't necessarily anticipate that psilocybin would be useful for folks who have these disorders. I want to talk a little bit about microdosing because I feel as though this is something that comes up all the time in popular culture. And you may have heard, tech CEOs talking about microdosing and it's supposed to help your creativity and do all these other things. And so I hate to burst your bubble, but I want to say that I am that microdosing makes me quite nervous as a psilocybin researcher, and I'll tell you why. So what microdosing is taking a sub-perceptual dose, so not something that should alter their, state of consciousness, pretty regularly, oftentimes multiple times per week, that is supposed to kind of help folks feel generally well, or be more creative, et cetera. Unfortunately, we are still learning about the safety profile of repeated doses of medicines like psilocybin. And in particular, psilocybin, in addition to activating that receptor I spoke of earlier, the 5-HT2A receptor, it also activates the 5-HT2B receptor. And so this one in particular, with sustained activation over and over and over again, as in the case of most microdosing schedules, it can actually hypothetically put someone at risk for structural heart disease. And so again, this is something that many clinicians and scientists within the psychedelic medicine space are actively researching. But at this point, microdosing, even though it is a lower dose than the dose we typically use within many of our trials, the repetition of dosing could actually be more dangerous. So again, the other thing I will say is that despite the touted benefits of microdosing, within clinical trials looking at this regimen, it hasn't yet been shown to be clinically beneficial. And so again, this is a huge caveat about microdosing, but I just wanted to share that word of caution just because there is so much kind of popular media representation of this practice. So another really, I think, exciting area of focus within the psychedelic medicine field is around ethics. And so there's nothing special about psychedelics. Ethics is really embedded within the field of medicine everywhere. And yet I think there's some important aspects of psychedelic medicine where ethical conversations become incredibly important just because of the vulnerability that arises in these altered states of consciousness. So an important one is talking about therapeutic boundaries. When folks take a medicine that makes them feel different, that can sometimes be confusing, and it's really important for providers and researchers to very closely maintain those therapeutic boundaries. I'll also say that in many of our psychedelic trials, our participants will ask to have their hand held when they are feeling fearful, should that arise during a psilocybin experience. And that's a little bit different than a normal, clinical therapy setting. And so, again, I mention that because it's a little bit different. And yet, if somebody were going into surgery, I know I would want my hand held. So there are these interesting kind of clinical contexts where anxiety or fear may arise, where, a handhold can be really indicated, but it brings up a very important ethical conversation about consent and touch. So informed consent overall is a really important area of ethical concern, and that it's hard to consent to a state where you may not feel like yourself for a period of hours. And so we try to be really deliberate about how we share with our participants about these experiences, just because that can, folks may not know what they're actually signing up for. I will also say that bias is something that comes into every domain of research. And so provider bias, researcher bias, everyone thinking that these medicines are definitely going to work or definitely not going to work can really influence how things go. Additionally, inclusion is another important topic within the psychedelic medicine space, wanting to make sure that we're offering these medicines and inclusion in our trials to a diverse population. And of course, appropriation of indigenous cultural practices is another concern. So all very important ethical considerations within psychedelic medicine. Another kind of interesting thing in that I described our research context, where we have two clinicians, oftentimes medically trained psychiatrists like me, doing a lot of psychotherapy and a day-long dosing session. And so, as you can imagine, this is a very labor-intensive process. And so questions around access to care, as psychedelic medicines get closer to approval and actual clinical use, are really important. And so, how do we figure out ways to make this clinically appropriate and accessible to all sorts of different folks? And so, again, really thinking about how do we expand care should these medicines one day be approved? And then finally, I'll just say a few words about hype. I mentioned hype, and I myself participated in some hyping of these medicines. And, I would argue that we're kind of at maybe beyond the peak of inflated expectations, and that, there's now been some negative press about psychedelics. MDMA was not FDA approved. We're moving towards this trough of disillusionment. And, I think that we're actually moving in the right direction towards more grounded, thoughtful appreciation for the true potential of these medicines, not overinflated expectations that they're going to cure everything and be appropriate for everyone, but really kind of this, we're looking to the horizon of this plateau of productivity where we continue to answer important questions about how this medicine may actually be useful for some folks. And so again, I just wanted to name the hype cycle because truly we are at this point in time where there's an enormous amount of focus on these medicines that may kind of go beyond the state of the science itself. And yet I think that only speaks to this hopefulness that we move closer and closer to answering the important questions that we need to. So next steps on women's health. I mention this because I'm passionate about it. And, we're increasingly looking for opportunities to expand psilocybin research across kind of the reproductive life cycle. Specifically, we do not currently have a study looking at menopause or perimenopause, but we would love one. And that's kind of a dream for our center, is to begin to support women in an important life transition that is often understudied and underappreciated. Likewise, there has never been a psilocybin study looking at postpartum depression, really an important moment of time in a woman's journey. There has now been some preliminary research looking at a novel psychedelic medicine that is again, another cousin to psilocybin. It actually works remarkably similar to psilocybin, but lasts a few hours shorter. And so that's kind of a new and emerging psychedelic, but not quite psilocybin, but something to stay tuned for in the future. And then finally, I just want to kind of give you guys a heads up just about some of the work that is happening at our center, and just say a few words about inclusion and exclusion criteria, because I know that, seeing a talk like this, you might want to go to our website and think about maybe joining one of our trials. And I encourage you to check out our website. And we have ongoing studies, as I said, in OCD, alcohol use disorder, major depression, opiate use disorder, post-traumatic stress disorder, We have a study upcoming looking at folks who have recently been diagnosed with ALS and looking again at some of that existential anxiety or depression. We have an ongoing study looking at depression and mild cognitive impairment. We have a new study starting looking at cannabis use disorder. And finally, yet another study looking at chronic lower back pain and comorbid depression. So many, many studies, and we're adding more every day. And so folks that may be eligible for our trials, that they are oftentimes, again, not including folks who have a primary diagnosis of schizophrenia or bipolar disorder or a close family history. Because again, with some of the genetics of these disorders, we would hate to put someone at increased risk. Active or recent suicidal ideation, again, just thinking about participant safety, and the research trial context is often pretty intensive, and that we would hate to exacerbate any underlying suicidality that was apparent in a participant, as well as some medical things. And this is kind of an excess of caution, a history of cardiovascular disease, seizure disorder, stroke, as well as kind of pretty profound substance use disorder. Although I did mention a number of studies that are starting for specific substance use disorders. And finally, one other thing I wanted to just share, I'm so excited about this. We are so happy to have an amazing psychiatrist, Dr. Azine Bakrad, who works with Johns Hopkins Personalized Care, who is going to be offering within her practice a consultation clinic for folks in the community that have had challenging experience with psychedelic medicines, or their family members have. And so I included her email here and just a little bit about that, because it is so important that, negative experiences do occur in the clinical trial environment, as well as with recreational use of medicines like psilocybin. And Johns Hopkins and, our community of researchers want to do everything we can to learn more about those experiences and meet the needs of individuals who are suffering. So I'm delighted to be able to speak to that. And finally, thank you for having me. Again, I feel so lucky to be a part of these conversations, especially, having this kind of focus on a woman's journey and women's health. And so I look forward to the dialogue and some of the questions, but thank you again for having me.
Great. Thank you so much, Dr. Yaden. That was wonderful. Absolutely great. Before we get started on the questions, though, I just want to clarify what you said in the beginning, that Johns Hopkins does not recommend the use of psilocybin unless it's under direct medical observation and only in a clinical setting.
100%.
Yes.
Absolutely not. And again, I want to provide all of this information because I do know there are these specific contexts where folks may have access to these medicines. But again, we don't know that outside of a clinical research setting that they are safe. So thank you for that opportunity to emphasize that once again, because the last thing we would want is this research to encourage folks to use these medicines recreationally that we don't know are safe or legal.
Right. Great. Thank you very much for clarifying that.
Totally.
So, in general, if you take psilocybin on a treatment, does this mean you'll be cured?
It's so funny. When I was in residency, whenever you hear the word cured, you should be nervous,
Okay.
because it's a very, it's an important word. And so I will say that we do not have strong evidence that certainly that psilocybin cures everything. And I am suspicious of the statement that it cures some things. What I will say is that, there is some compelling evidence that with certain study populations and certain individuals that they can have remission of symptoms. So again, I sometimes the C word, the cure word is,
Right.
we don't like to use it. And yet, I think that for many folks in our studies, they do have some symptom relief that's really encouraging.
Mm-hmm. Great. Good clarification there. Thank you very
Thank
much.
you.
All right. Our question from Marty. Are there consistent doses of psilocybin just as there are for traditional pharmaceuticals?
Absolutely. Yeah. And so this is, again, something that, within our clinical research setting, we are using synthesized psilocybin. So in a recreational setting where folks are taking, uh, you know, actual mushrooms or truffles or other things, that is not regulated. And so there's no way to know how much of the active ingredient psilocybin is in them. But within our studies, these are pills with doses at, like any other medicine. And so, specifically within our trials, the standard dose of psilocybin that we use is usually around 25 milligrams, sometimes higher, sometimes lower, depending on the indication. But absolutely, these are, standardized doses of the medicine.
So would you say then too, for these doses, like you were talking about, it depends on the individual as well, like what their history is, and also if they're sensitive to medicines, or they may have other issues going on. And I would imagine just like any other pharmaceutical drug, right? Would you say?
Absolutely. And so, in some ways it is hard for us to predict what kind of experience someone will have at that standard
Mhm,
dose.
mhm.
One thing that is interesting that we're still learning about is that, within our trials, we do not often, some of our trials, it really depends on the study. Increasingly, we are not asking folks to wean off of if they're taking SSRIs at the same time. And so
Right,
some folks will say, well, maybe taking psilocybin and an SSRI can impact the subjective experience of psilocybin. Interestingly, this hasn't been shown in research yet. It's more anecdotal. But I will say that there's a number of factors. What you had for breakfast,
sure.
what your baseline metabolism is. There's a number of things that can impact how someone experiences that dose. But many of our studies, because they're within this clinical context, clinical research context, use that established dose.
Great. Yep, start off small. So which
Yes.
actually brings us to the next question from Jenny. When you talked about the SSRIs,
Yeah.
so our question is it true that psilocybin is ineffective if one is taking an SSRI?
So it is not true that it is ineffective. And it is often for our participants actually just as effective. And so, the funny thing, there's amazing humility in research, I will say. Sometimes we tell ourselves, oh man, this person's on an SSRI, maybe it won't be as effective, maybe it'll blunt the effects.
Mhm.
And we just haven't seen that consistently. And so in the few studies that have looked at this specifically, they did not show a difference. But that being said, I think we're learning that there could be some mechanisms that would slightly reduce the impact of the psilocybin experience, but that doesn't necessarily mean it would be less effective. There's a few exceptions in that there's a few antidepressant medicines that do actively counteract the receptor activity of psilocybin. For instance, trazodone, which is a 5-HT2A antagonist. So not an SSRI, but an antidepressant that does stop the effects. So that was a long-winded way of me saying that we're still learning about this. For the most part, we find that folks have a significant psilocybin experience, even while still taking their SSRI medications. But there's a few antidepressants that are the exception.
Mhm. Well, I think it was important anyway for you to clarify that, and thank you so much for that.
Yeah.
So our next question will be from M.A. Brown, and they want to know, is there an equivalent mushroom species in Europe?
I don't know. I am not as well versed in kind of the grown psilocybin world. And so full disclosure, I have absolutely no idea. I have heard that the psilocybin mushroom or mushrooms that have psilocybin do show up in other parts of the world, but I do not know a lot about it. So
Mhm.
apologies for that.
No, it's just something we all get to learn then later on. We can all look that up on the Hopkins website, though,
Thank you.
not on the internet. Yep. Okay, our next question is from Ellen, and you touched on this during your presentation. So what about microdosing? How many millimeters per dose is question number one. And the other one is how frequently can you use it? Oh, there's three questions. So I'm going to let you do the first one.
Totally. We'll
so-
wrap them all up
Yeah.
together.
So
So
how many
here's
how many millimeters per dose? How frequently can you use it? And what's the effectiveness? That's the total question.
yeah. So always happy to talk about this. And full disclosure, I am not a microdosing researcher. Our center may end up doing a microdose study sometime in the future, but I can say that um, there are, the internet propagates all sorts of kinds of recommended recreational doses of these medicines, none of which can I recommend. So there is no, as far as I know, there's no safe microdosing amount. Because again, like this is not something that we recommend outside of the clinical research environment. So I can't really speak to specific doses. In terms of frequency, again, one of the pitfalls of microdosing or concerns there is that the repeated dosing schedule could, again, put someone at risk for this very specific health outcome that's associated with certain medicines that activate the same receptor, the 5-HT2B receptor that psilocybin and some other medicines activate. And just because we haven't done extensive research in long-term research with microdosing, we can't speak to its safety. So in the studies that I've been talking about, they're designed such that someone gets a large dose, a macro dose of psilocybin, ideally only twice in a certain treatment period. And so, or maybe even once. And so the idea here is not to expose the body over and over again to a medicine that over time could lead to negative health outcomes, but really to only do it selectively. And so again, a somewhat unclear safety profile for microdosing. And again, the efficacy is something that has yet to be established. So there's a lot of folks that talk a lot about microdosing being useful, but we don't have any studies yet that show that it's actually beneficial.
Thank you. So on that, so if you go in for a treatment,
Yeah.
one treatment, okay, and you said that usually lasts how long? One full treatment?
So kind of the treatment course, and this is different by study to study.
Mhm.
Within many of our trials, the active treatment period is about 8 weeks, where we go through that preparation period of really getting to know our participants, an active dosing session or two, usually spaced by about a week or two apart, and then those ongoing integration sessions. So that kind of whole treatment period typically lasts 2 to 3 months. The dosing session itself is an 8-hour period where folks get in early in the morning, take a medicine, lay on the couch all day, and then, a little bit before 5 p.m., go home to their families.
So if you're in the middle of a treatment and let's just say it's not going, as well as
Yeah.
everyone would like to, can a physician get you out of that? Or do you have
So
to
we
let it
do.
run its course?
That's a great question. So there's a number of things that the providers can offer in those moments. And so we kind of stratify them. We start with just talking, checking in. How are you? How can we offer you support in this moment? And oftentimes that alleviates a lot of the anxiety that's coming up.
Sure.
And it often shifts pretty quickly.
Right.
After that, we then can offer folks within our clinical trials. Usually we'll provide an anxiety medication that usually really blunts that anxiety, really reduces some of those subjective effects. And then we even have some other medications that act on that same receptor, that 5-HT2A receptor, and kind of inactivate it, that can also kind of contribute to limiting the psychedelic experience. And so we describe these as rescue medications, but really they're just kind of clinical supportive tools that if we need them, and most of the time, almost always, we don't end up actually needing to use them.
Right.
But we have them. We also have other medicines I will say that psilocybin during the acute subjective effects will very modestly increase people's blood pressure. So we have medications that can help reduce people's blood pressure, other kinds of medications available. But again, we're not having to use those really with any regularity.
Right. So are you actually interacting with the patient during the treatment, once you give them the psilocybin, or are you just sort of, I know you're monitoring them, but are you just sort of letting them kind of letting the medicine sort of do what it's supposed to be doing?
We let it do what it's doing. And, for the most part, we try to get out of the way. In that for most of our participants, they have a lot of thoughts to have and things to process. And we try not to distract them from that experience. And so we are present with them, always two people in the room at the same time,
Right.
where we can be there to offer encouragement or support or get them a glass of water or an extra blanket. But typically we're not engaging in what you would think of as a more intensive psychotherapeutic process
Right.
with psilocybin.
Great. That's a great explanation. It's good to know that, because it can be scary.
It can be scary for sure.
Yeah,
And again,
yeah.
that's why there's so much care put into this set and setting component of the clinical research environment, because we know that this makes people feel vulnerable.
Right.
It has the potential to support, to help them towards their treatment goals, but can really, bring on some of those feelings of panic or fear.
Great. Thank you very much for that. So
Yeah.
our next question from Phoebe. She'd like to know, how long will the psilocybin treatment be taken for, and are there certain medications or foods that cannot be used in conjunction?
That's a really lovely question. So in terms of the foods, there are some medicines and foods that we know may make the psilocybin less effective. Specifically, we tell folks not to eat grapefruit because there's some concerns about the enzymatic activity of grapefruit. It's not dangerous necessarily. It may just change the subjective effects. There are, again, some of those medicines that I mentioned that can blunt or prevent the psychological effects of psilocybin. Um, there is not a number of medications a long list of medications that I would say increase the toxicity of psilocybin. So, that I think is helpful. It's not like some other psychedelic medicines that when used with other things can really put someone at risk or at risk in the same way. Again, by no means would I encourage anyone taking psilocybin to then take a number of other medications. And again, we are learning about some of those drug-drug interactions. We don't know all of them at this point, but have some idea about, a basic safety profile of psilocybin. But this is not the case for many other psychedelic medicines, such as MDMA.
Great. Thank you very much.
Yeah.
Our next question is from Anne, and she'd like to know, has there been any studies addressing borderline personality disorder with psilocybin?
Great question. So there has not yet. I think that there are a number of studies that have not excluded for borderline personality disorder. And so I wish I could quote specifically the study and it may actually not have been a study. It may have just been kind of the report of some other researchers at other institutions that had shown at least, and again, this is not necessarily published, but that there could be some benefit, or at least that it was safe in the very few participants that may have received it within a very particular clinical trial. That being said, I think that that's a really important question, because I think that population in particular is vulnerable and needs to be very well taken care of. And psilocybin can be very destabilizing for some people. And so I think it's just really important that, folks who have borderline personality disorder are very supported if they were to go through this treatment or to participate in a clinical trial, just because it can be somewhat unpredictable.
Great. Thank you very much, Dr. Yaden.
Yeah.
Our next question from Cameron. Are you of the belief that psychedelic medicines, prescriptions such as psilocybin, and he has MDMA, which you might elaborate on,
perfect.
are, are a magic bullet in of themselves, or do you believe that such psychedelic medicines are an advanced tool for psychiatrists?
This is a great question, and let me restate it to make sure I got it. So,
Yes.
you know,
Complicate, yeah.
I think that, are they a magic bullet? Like, is the idea that
Mhm.
anybody can take a psychedelic medicine and just be better? Or should these be kind of contained within a psychotherapeutic framework or a psychiatric one? And I think
Right.
I really firmly stand on the latter, and that I think that these are medicines. And I think that medicines are best used in with the oversight of a clinician and a supportive context. And so, I think that we are still learning about the therapeutic mechanisms of things like psilocybin. However, I think that the medical world itself has a real responsibility to patients to create a container where they can safely experience these things. And so I think that having therapy, having a therapist to prepare you for a psilocybin experience is imperative, or at least some kind of psychological support that allows for people to feel safe. I think that having a responsible provider there to help you integrate that experience, to make meaning out of something that might have been confusing or frightening or, life-changing. And so I feel like embedding psilocybin and keeping it staunchly within this medical world is really important.
Great, thank you very much. Just to go back to the dosing for a second, because just for
Yeah.
clarification, Whitney, and she did say, sorry to ask you to repeat, just so you know.
Yeah.
But did you say the dose in your trials is 25 milligrams, the hero dose, or is it 5 grams?
So here is an important clarification. So in the recreational use of psilocybin mushrooms, things are often spoken about in terms of grams. And so I can't even like I am not familiar with that world really at all. So I can't speak to the number of psilocybin mushroom grams that would be the equivalent of what we're using in our studies. What we use is 25 milligrams of just that synthesized molecule psilocybin. And so it's a bit different. It can be confusing because I think, you hear these things talked about in grams, but then we're talking about them in milligrams. And so it's kind of apples to oranges in that way. But yes, a dose that is used in many of our trials is 25 milligrams.
And that would be like your minimum dosage to see any therapeutic effect?
So we don't know yet. I will say that there are some studies actually, and these are interesting. There have been some research out of Yale looking at psilocybin for the use in migraine and cluster headaches, and they use a dose of about 10 milligrams. And so again, they're not looking necessarily about the psychological effects of the medicine, but really just looking about how it kind of works in the brain in terms of headache.
Mhm.
And I would this is not my area, so I don't want to misquote that literature. But I will say that there's, some acute subjective effects that do occur at lower doses, and we're still learning about the dose that's optimum. In some studies in Europe, they use a lower dose and engage in more kind of psychotherapeutic talking, which is somewhat different than the model here in the US.
Right, great, thank you.
Yeah.
Um, So we just have a quick little, I got a minute, I'm sorry before I have to wrap it up. But Kat would like to know, is this also being researched in effectiveness for PTSD?
Yeah, it is. We're actually actively uh, doing a study of psilocybin for PTSD. You can find, the screener on our website, and it's a really meaningful study. I'm one of the clinicians involved with it, and so again, we don't know if it's helpful for any of these disorders that we continue to study and research, but I think that it's a patient population that really deserves support, and so hopefully this can be another tool in that toolkit in the future.
Great. Thank you so much, Dr. Yaden. This was just incredible information. I mean, all cutting edge, as you alluded to, and really sounds like there's really some promise here for a lot of people out there and hope.
I certainly feel that way. And again, I am in the research world, so like we really don't know. I mean, we're learning from the research every day. And yet I feel like there's so many folks out there that deserve good solutions. And
Yep.
I am also hopeful that maybe psilocybin someday can be a resource for folks. And so thank you so much for the opportunity to be a part of this chat. It was just a pleasure as it was last year. And so
Yes.
thank you again. And
Well,
yeah,
thank you. Thank you so much again. And Dr. Yaden has graciously agreed to respond to any unanswered questions that were asked this evening. So in a couple weeks, you'll receive an email with the answers to any outstanding questions and the answers. A video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/awomansjourney under videos on demand. And if you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/awomansjourney, for more information about upcoming live programs, webinars, podcasts, and our monthly email, and especially read about our forthcoming event on November 23rd in Baltimore at the Marriott Waterfront Hotel. And you can register online for our 30th anniversary celebration of A Women's Journey live. I hope to see you there. Good night and stay well.